Assalamu alaikum wa rahmatullahi wa barakatuh. So this is the second lecture that's going to be talking about principles of fractures. One of the most important lectures, one of the lectures I really like. It's fun, it has a lot of biomechanics. So let's get started. So as you can see in this X-ray, this is an X-ray, a normal for a right hip joint, showing the femur and the right hemipelvis. But if you look to the other side, we can see a discontinuity of the bone in here, and there is a deformity for this hip. So for medical students who first see this X-ray for the first time, it's going to be, wow, what should I do with this X-ray? Don't worry, we will stick to the principles. And after this lecture, we will know how to describe this X-ray and the morphology. Just to let you know that we will be having a special lecture only and only for reading fractures. So don't hurry to read the fracture now. Okay. So our objectives for this lecture is to understand the principles of a fractures. What principles? The type of displacement. What is the type of healing, which is very important. Clinical and imaging. So these are the core, and understand the general principles of treatment. So we will talk about the fractures, types, healing, and the principles of treatment. As we already said in the last lecture, that the bone is composed of collagen type 1 mostly and hydroxyapatite, calcium and phosphorus. And the bone structure, we have the woven bone, which is the newly made bone that's having the calcium and phosphate. And we have the lamellar bone, which is the mature, okay? The lamellar bone, we have the cortical. As you can see here, this is the cortical bone that we already mentioned. And we have the cancellous, or the spongy bone. This is the spongy bone, okay? We have in the cortical bone the osteon, which is the vascular core. As you can see here, the osteon and the Haversian system between them. And this is the cancellous bone, which is the spongy bone. Please keep in mind that the bone is a living tissue. It's not a rock. It's always in remodeling. So treat bone as a living tissue. When you have a patient in the emergency room that's having, or you are thinking that he's having a fracture, please treat him according to the ATLS way, the Advanced Trauma Life Support. You should go through the ABCDEs, which is the airway and C-spine, breathing, ventilation, oxygenation, circulation, and you have to stop the bleeding, disability, and to finish finally with the exposure and the secondary survey. So you have to finish the primary survey, then you have to focus on the limb. Usually limb injuries are distracting for the doctors. So keep in mind ABCDEs, then the limbs, unless it's a major bleeding and you will treat it in C. So we already talked about this, the primary survey, secondary, and transfer to definitive care. A lot of trauma x-rays. For example, this x-ray, you can see here on the right side, the pneumothorax, the massive pneumothorax that the patient had. Maybe he's having another fractures in the lower limb, but it's not important. Now it's time to save the life. Okay, for the clinical evaluation, you have to take history, physical examination, then investigations. So in the history, it's very important, it's mandatory, very important to take the mechanism of injury. And we in orthopedics, the history of presenting illness is usually the mechanism of injury. How did he fall? Was it is a high or low energy trauma? If it was an RTA, what happened to the passenger? Any broken glass? If the car flipped, what happened to the other car? So these information are paramount to know if it's high or low energy trauma. It's very important. The patient usually complains from pain, swelling, bruising in his limbs. So you have to take this in consideration, inability to move his limb. And if it's the lower limb, the patient might be complaining that he's unable to bear weight, so he can't walk. Deformity usually is obvious. And the nice thing in orthopedics that you have two limbs. You have two limbs to compare. You can compare the right limb to the left limb. Associated injuries, if there is a neurovascular injury, you have to check for the pulses, you have to check for the dermatomes, myotomes, reflexes, and so on. shock and hemorrhage. Shock is very, very important to diagnose, and don't wait for the shock for the blood pressure to go down because you are already too late. You have to expect shock by the energy mechanism, like the mechanism of trauma, and manage it upon this. Okay, for the clinical features, we have local signs and we have general signs. And usually in orthopedics, we do this sequence of examination, which is the look, feel, and move. So by looking, you can look at many things. First of all, symmetry. Symmetry, you have to compare the two limbs together. Swelling, bruises, deformity, you can look for the skin, open wounds, pulsatile masses, and so whatever by only looking. Feel, then we go to feel. Feel, we can feel the local tenderness if the patient is conscious. If he's not, we will be looking for other signs. Maybe you can feel subcutaneous emphysema, you can feel the crepitus of the fracture itself. You have to examine the distal neurovascular, the pulses and the nerves. It's very important. And if you want to do reduction for the fracture, you have to write before and after the reduction. It's very important for the medical legal issues. Finally, the move. In the movement, we have two types. We have the passive and the active. The active, that the patient is moving alone, and the passive, you are moving the patient. Usually, or always, we start with the active. We leave the patient to move his limbs, then we will move him. Because if you will move him, you don't know what's the limitation of the pain for this patient, if there's any fractures and so on. So we let him actively start. And after he moves, we know the range of motion, we have an idea now, so we do the passive. And we feel for crepitations, abnormal movement, and usually we move distal to the fracture. And finally, we go for special test. We will be talking about the special test for each joint and limb alone. Usually when you have an X-ray, you have to have roll of two. What's roll of two? Usually it's applied to the limbs. We should have two views, AP and lateral, two joints, one above and one below, so we know the rotation, if there's rotation or no. Two limbs to compare, especially in pediatric age groups because there is epiphyseal lines. Two injuries, if you're expecting like for the scaphoid fracture, it could be having, for example, falling on outstretched hand, he might have scaphoid, he might have distal radius, he might have elbow fractures. So this is important to expect injuries by the mechanism of injury. Two occasions is pre and post reduction and for follow-up, because as we mentioned, scaphoid fracture, sometimes after injury, you cannot really see it. So you have to redo the X-ray after 2 weeks so you can see it because you will have signs of healing. We have some special imaging like CT scan, MRI, radioisotope scans, and so on. These are further investigations, depends on the surgeon or the orthopedic surgeon. This is a scaphoid. Here you can see the scaphoid in here. You can see the line. This is the line of the fracture another time. Okay, now description. When you have a patient in the emergency room and you want to describe the fracture, it's very important to do these points. First of all, you have to know that is this fracture open or closed? What's open? Open means that the skin over the fracture is opened. If it's closed, so this is a closed fracture. It's very important. And we have a classification for the open fractures. It's called Cancellous classification. We have many types depending on the size of the wound, the vascular injury, periosteal stripping, high energy trauma, and so on. Okay, you can refer to it. It's called Cancellous classification for open wounds. Which bone and where? So for example, let's say there is a forearm fracture, ulnar or radial fracture. This is the bone, and where in the bone? Is it in the epiphysis, intra-articular? Is it in the metaphyseal region, or is it in the diaphyseal region? If it is in the diaphysis, is it proximal third, middle third, or distal third? So we have to know where is the fracture. Has it involved a joint surface? It's very important, guys, when you have a fracture to know if this fracture is intra-articular or extra-articular. Is it inside the joint or outside the joint? Because if it's inside the joint, I will be thinking about osteoarthritis. Okay, this patient might be having osteoarthritis, stiffness, muscle wasting because of fracture, disuse, and so on. What's the shape, the morphology of the fracture? And we will talk about this in a minute. Is it transverse, spiral, oblique, butterfly? Displacement. As you all know, when you have a fracture, sometimes you will have a deformity. So the distal part might be going either inferior, okay, or superior, or it's going translated, lateral or medial. So you have these bone parts, and it could be having an angle. So this is called the displacement. We have to describe the displacement. The secondary injuries, we have spinal cord injuries, pelvic and abdominal trauma for sure, thoracic injuries, peripheral nerves and vascular, skin, muscle, and tendon injuries. Time, let's go back a little bit in the time. Usually they used to splint like this in the ancient history. When someone had a fracture, they used to splint him like this. And the first external splint was done in 1500. That's why it's called plaster of Paris. Plaster of Paris, POP. Then in 1897, they have the external fixator. You are fixing the bone, but externally, not internally. Then came people like 1886, and they started to do fixation of fractures, external and internal. The problem, we have something called fracture disease. Okay, we have a fracture. What will happen to the limb if the fracture is there? There will be joint stiffness because there is pain. The patient cannot move the joint, so there will be stiffness. There will be wasting of the muscles, skin atrophy, and sometimes circulatory dysfunction. So the fracture disease, as Perkins says, that it's because of the treatment, not the fracture itself. Any fracture will heal, but when you treat it conservatively, for example, with a splint for 8, 12 weeks, you will lose the muscle, you will lose the vasculature, and so on. So how fractures happen? Usually, either it's an injury, acute trauma, okay? Either repetitive stress or pathological. So it's either a direct trauma, it will break the bone, repetitive stress, okay, like the army or the dancers or the sports people, and finally pathological. For the morphology of any fracture, you have, for example, this transverse fracture. Usually transverse fracture, you take an axis. This is the axis of the femur, okay? Sorry. So this is the axis of the femur, and this is the axis of the fracture. If the angle between the fracture and the axis of the femur is less than 30, okay, this is called transverse. If it's more, it will be like this, oblique. Okay, so transverse, oblique, and this is called spiral, which goes into 3 points. Okay, so in the morphology, transverse, oblique, this one, spiral, as you can see in this X-ray. We have something called green stick, which is specifically for pediatric age groups. When they have more elastic bone, the cortex only break from one side, usually from the tension side, which is this side. This side has nothing to do with the fracture. And if you have more than two pieces, so like this picture, it will be named comminuted fracture, okay? So transverse, oblique, spiral, green stick, and comminuted. This is displaced. You can see the displacement in here. So if I want to describe the displacement, okay, there is angulation, because if you can take this axis and this axis, they will be having an angle. So it's angulated, okay? It is displaced medially. So it's going varus or medially, okay? And this point, let's say there is shortening, for example. So this is how you do description of the fracture. So if you have a fracture, what really we do need, we have to restore the geometry and the structure, okay? The length, alignment, rotation. We have to restore the length, the alignment, and the rotation. These are the 3 main things in the recovery of any fracture, okay? And Mr. Apley says, a broken bone heals because it's broken. If it's not broken, it won't heal. So the first step in fracture healing is fracture. Okay, too much details. I'm trying to make it as simple as possible. Okay, for the environment, we have two things. We have something called the biological and the mechanical environment. The biological and the mechanical environment. The biological means that you have good blood supply, okay? There is not high energy trauma, everything's fine, the bone will heal because you didn't do stripping. The mechanical, that you fix the bone in the right way, that we will be talking about later. So for example, this picture after 8 months and the patient is not having union. The fracture is not healing. You can see after 8 months that the fracture is still there. So there is a problem we will be talking about later. On the other hand, this picture shows you that this plate is going inside. You can see the size of this incision in comparison with the size of this incision. This incision is very big, periosteal stripping, soft tissue damage, so there will be no blood supply to the bone, less healing. But this side, which is called minimal invasive, is better. So the biological environment on the left side is much better than the right side. This is another example. For a femur fracture, you can see it here, was fixed by a long plate only by these incisions, which is called minimal invasive. Less invasive means better healing because better blood to the bone. Okay, if you look at this X-ray, you can see this femur is having a fracture here, and the plate that already surgeon put it was broken too. So if you look only by the X-ray, you will say, oh, this is very bad. This is a mechanical failure because the screws and the plates are bad. But when you look at the soft tissue, you can see the surgery. Look at the incision, how big it is. No blood supply, disturbation of the periosteum and the soft tissue around, no blood, no bone healing. So this is biological failure, okay? So the idea of this, you have to know that in biology, last lecture, we talked about the blood supply to the bone, the periosteum, endosteum, and the nutrient arteries, okay? So you have to keep this in place. Fractures must have blood to heal. And as we mentioned, from the endosteum is going to have 2/3, from the periosteum is having 1/3 to fracture healing. The principle of the banana is that when you strip the bone, and you put the plate, okay, the fracture won't heal because you diminished the blood flow to the bone. On the other hand, when you open just only 2 small incisions like this and you put the plate, the fracture will heal better because you didn't disturb the fracture environment. So it's very important to keep in mind. I think this is the most important thing in the lecture of the fractures. How does a fracture heal? The fracture heals in 2 major ways, okay? We have the direct and the indirect, primary and secondary. So what's the difference between the direct and the indirect? Let's start with the indirect. The indirect is about callus formation. Callus is when you do X-ray, you can see a lot of blood and then inflammation, then calcium is coming, deposition. So you can see a bag of bone like it's going around the fracture. On the direct, there is no callus formation. So in the indirect, when you want to see callus formation, the secondary, the first thing to happen is the impact. As you can see in this picture, you have a trauma. After the trauma, immediately there will be bleeding, hematoma. Hematoma is the first stage of fracture healing by secondary bone healing. And you can see histologically here a lot of blood. After the blood, you know there is swelling, redness, hotness, which is inflammatory process. So hematoma, inflammation, which is a granulation tissue. And after that, it's called callus formation, which is the soft callus. So you remember in the last lecture that the osteoid start to get here, then calcium and phosphate are deposited inside the minerals, which is called the woven bone, and finally it will go to lamellar bone. So here, callus formation, and you can see it's going beyond the edges of the original bone. This is the soft callus in here, and this is a nice histological view for the callus, how it's being formed. This is the periosteum that's covering the fracture. Consolidation, which is the hard callus, it's called, so soft callus, hard callus, consolidation. You can see that there is obliteration of the medullary canal in here. And you can see in this X-ray how the callus looks like. It's like a circle outside the bone edges. Here you can say that the fracture is healed and the patient goes home, no pain, he's living his normal life, but still remodeling is gonna happen in the last stage, which is called remodeling or recanalization. So these are the normal 5 steps of the indirect bone healing. This is a picture for a distal radius fracture for a kid, and after 8 months, look at the X-ray, only by remodeling this happened. So we're done with the indirect, the secondary bone healing, callus formation. Let's go for the first one. So the first one is called the direct fracture healing, direct fracture healing. So what's direct fracture healing? Which is no callus formation. But if you want to go for the direct bone healing, you have to have some principles. Basically, you have to have 2 rules or prerequisites. The first requisite, if this is the fracture line, okay, the fracture should be not moving at all. It should be rigid, like this, fixed to each other, no movement. The other prerequisite, that the fracture distance between the 2 edges must be less than 2 millimeters. So if we have this line less than 2 millimeters and there is no movement, primary bone healing will happen. So what will happen? There is something called cutting cones, as you can see on this picture. What's the cutting cones? It's an army of an osteoclasts, like an arrow, an osteoclasts, and behind them an osteoblast. They can jump over the fracture if it's not moving, like rigid, and if the distance is less than 2 millimeters. So the cutting cones can pass, which is the osteoclast, and behind them the osteoblast. And you can see here on the histological picture, here the osteoclasts are in front of the osteoblast in here. So if the, as you can see in this picture, this is the fracture line. The cutting cones can go because it's less than 2 millimeters and it's rigid. It's not moving at all. It's rigid fixation. So there will be primary. So if you follow up this patient for the next weeks, you will never see callus formation. You will see the line of the fracture is getting less and less until it goes away. So this is the primary bone healing, the cutting cones. I hope it's clear. How fractures happens. We already have this, that we have direct trauma, then we go through primary or secondary bone healing. It's very important to know how the fracture happened, the mechanism of injury, to expect how or what the morphology of the fracture is, like transverse, oblique, spiral. Usually, when you have a direct trauma, you should have a transverse fracture. So direct trauma, transverse fracture, this is high energy trauma in the site of the fracture. If it's compression, okay, or bending, it could have a butterfly, okay? Bending with compression could have a butterfly. So depending on if it's from the proximal part is fixed and the distal is rotated like this, for example, like the people who are skiing, you will have a spiral fracture. It's low energy, but it's a long fracture as the people who are doing skiing. Direct trauma, you will have a transverse fracture, as you can see here in the olecranon, okay? Or in some cases, it could be an avulsion fracture. Avulsion means that the tendon is holding the tip of the bone. The action of the muscle continues while the limb is in place. So the muscle will contract and will fracture the bone in an avulsion fracture. There are a lot of classifications for fractures, and you will see in the next videos that on each region we have different classifications. Okay, we have one of them is the AO classification, which is not mandatory for you as students to know, but whenever we have an important classification, I will point it up for you. But here you can see this is a transverse fracture, this is a butterfly, this is comminuted, this is intra-articular. This is extra-articular fracture outside the joint. This is intra-articular fracture, okay? This is the classification of the AO. You don't have to know it now. Okay. You have to know that it's low energy or high energy trauma. Okay, low energy is like spiral when you have rotation. Okay, it's moderate soft tissue injury. High energy like comminuted or transverse fracture, it will cause severe soft tissue injury. Soft tissue means the muscles, the nerves, the arteries, the skin, so whatever. They will have much damage because of the high energy trauma. One type of the fracture for the pediatrics is called the incomplete fracture or the green stick fractures. You can see that there is a fracture in here, okay, and the bone is bended, but there is continuity in the bone. The bone is continuous. It's only bent. This is called green stick fracture. You can see here also this hump, it's called buccal fracture. Okay, it's type of the green stick fracture for the pediatrics. So for the complete fractures, we have transverse, oblique, spinal, impacted, and comminuted. This is called repetitive stress. Usually for dancers, sports, army people, they keep on pressure on the same limb, and at the end they will have sclerosis in here, and you can see here callus formation. So it's normal bone, but you have abnormal forces. A lot of tremendous forces coming to the bone. So it's a normal bone. Athletes, armies, and dancers. On the other hand, we have something called pathological fracture. It's normal forces, but abnormal bone. The bone is weak. Either as here, we have a bone cyst, which makes the bone weaker. And this is part of the incomplete fracture, which is the green stick or the buccal fracture. Now we want to talk about the displacement of the fracture. We can talk about the apposition, the shifting, in which axis is going into varus, into valgus. It's going inside or outside, medial or lateral. Okay. Is there any overlap, shortening or not? Alignment, if there is any tilting. Okay. You should say if it's going, if I have any tilting, it's the angle between the proximal and distal part. You can say it's going valgus or varus. The rotation, it's very important, but you have to have the role of two joints to know if it's rotated or not. So why fractures get displaced? Because either the force itself, when you have the impact, the trauma, the fracture will displace, the gravity may displace the fracture, and finally the pull of the muscles. So these are called the deforming forces for any fracture. This special type for pediatrics fracture, because you know they have epiphyseal line here, it's called Salter-Harris classification. Salter-Harris, it's very important. Salter-Harris classification. Type 1 is through the epiphysis, the fracture. Type 2 through the epiphysis with part of the metaphysis. Type 3 through the epiphysis with part of the articular surface. And type 4, both metaphysis and epiphysis. Part 5, which is compression, which is complete destruction of the epiphyseal line. In orthopedics, whenever you go to the next level of the classification, that means it's worse in prognosis, usually. Okay. This is type 2, this is type 4, type 3, and that's it. Okay, for the treatment, you have to reduce, hold, exercise. Reduce the fracture, hold it, then exercise. So what we are looking for in the vessel fracture, as I said before, length, alignment, rotation. Restore the length of the bone, the alignment, okay, and rotation. So this is very important to restore. We have to point, please, if you have an intra-articular fracture inside the joint, please, you have to reduce it anatomically. It has to be like the book of the anatomy. The pieces has to come together as in the anatomy. And when you fix it, the stability be fixed immediately like rigid fixation. So that will take us to something called rigid fixation, which is with screws or plate, okay, and stability. So we have reduction and stability. The reduction, it can be anatomical as the anatomy book, or functional, like restore the length, alignment, and rotation. It will be functional. And for the fixation, for the stability, it can be rigid fixation or relative. For the intra-articular fracture, on this slide, the fracture should be reduced anatomically, anatomical reduction with absolute stability or rigid fixation. There should be no movement and the distance less than 2 millimeters. So we will allow the intra-articular fracture to heal by primary bone healing, no callus. Okay, but if it's extra-articular like femur fracture, restore the length, alignment, and rotation, functional reduction, and relative stability, like the intramedullary nail that we will be talking about later. So fracture treatment, closed or open, give antibiotic for open, hold and reduce, either you splint it, cast, and you can go for internal or external fixation. You can fix a fracture with plates or screws, which is called internal fixation. Before 50 years, look at the fixation. It was very poor. Nowadays, it's much more better. You can see this is an intra-articular fracture in an elbow. And after that, it was fixed very nicely with plates and screws. And the outcome for the patient is perfect because the articular surface, as you can see here, returned to normal. Primary bone healing, no callus formation, rigid fixation. So what made the difference? AO trauma, thankfully, they had some principles, and you can see in this picture, any fracture will heal. But we as orthopedic surgeons, we shift the healing of the fracture, either primary or secondary, as we need. So what's this? This is a fracture. Yes, it is a fracture, but this is a severe soft tissue injury. So please think about the soft tissue, the blood supply. Please preserve the blood supply, early range of motion. That's why we put screws and nails and so on, so the patient can return to his normal life, reduce and fix. Don't forget the banana principle we already talked about. And these are some pictures for complications of internal fixation, that you have infection, non-union, failure, or re-fracture. This is an external fixator, one type of the external fixator. It's called Elizarov fixator. A lot of external fixator can be used in all over the body. One type of the fixators that used in King Hussein Medical Center a long time ago. So immediate wound recovery for open fractures, early wound debridement, antibiotic, and stabilization. For the general complications, you can have shock, respiratory dysfunction, metabolic response syndrome, crush syndrome, DVTs, tetanus, gangrene, and fat embolism. Locally, you can have blisters, muscles, vascular injury compartment, bone infection, malunion, non-union, or delayed union, joint hemiarthrosis, infections, RSD, reflex sympathetic dystrophy. And this is a picture of non-union and local complication. In summary, understand the principles of fractures. This is one of the most important lectures. If you didn't understand anything, you can ask in the comments. You can go back and re-watch the video, know the general principles and treatment of the fractures, and thank you very much.